Great. Thank you so much. Well, good evening, everybody. It's a great pleasure to be with you here tonight. I hope you all had a good day. I'm really excited to have this opportunity to speak to you on a really important topic, which I know all of us are very interested in because it's something that affects us daily. This is one of the most universally talked about topics and the thing that really connects us as dental professionals. And that, of course, is managing surgical extractions, but doing so with confidence. So I'm really excited for this opportunity. There is so much information to cover. This is a course that I could give over 2 full days. But of course, we have just about 1 hour. So I'm going to do my best to get you through as much of this information as possible, provide you an invitation to the unique offering at the end. And then, as mentioned, stick around at the end for as many questions as you need to be answered. So a quick thank you, of course, to Catapult Education. I'm very honored to be a member of this great organization. And again, a big thank you to them for helping host this event. So I just wanted to start real quick with some background information. As I mentioned, extractions are something that link us all together as dental professionals. We extract over 20 million teeth per year, and over 40% of our population over the age of 60 has at least one edentulous site. So even though the rate of bone grafting is going up higher and higher, the numbers are actually shocking as to how little grafting is being done. And of course, a lot of that is due to fear and lack of confidence and a lack of understanding of what techniques to use, what materials to use, how to even take out these teeth in an atraumatic form to begin with. So what we all are so concerned about is that one thing we can all appreciate is that when we do extract teeth, there is a major change both in the functional and the aesthetic outcomes. And this is what ultimately makes extractions such a difficult, challenging, and frankly, for many of us, a fearful type of topic. Because we know once we touch this tooth and we remove it, that our technique is going to make a huge impact. And that after that site heals, there are going to be dramatic functional and aesthetic changes, which ultimately are going to lead to our success and our patients' happiness. So, of course, we want to do the best job possible. And if we're not fully confident in being able to do that, well, now the hesitation and the doubt starts to creep in, and we're not sure if we're going to be in the best situated place to get this job done. Well, of course, that's why we're here tonight. Now, our biggest fear that we are trying to avoid at all costs are situations like this. Sure, we may have been able to take a tooth out, but now we're left in these areas again with these functional and aesthetic compromises. Now, it might be in the aesthetic zone, which in the maxillary anterior we know is the biggest area the patients care about, and it just so happens to be the area where we have the thinnest buccal plate in our entire mouth. So the functional and aesthetic concerns we have in that area are monumental. But when we look at even these other situations, how confident and comfortable will you feel placing a bridge on that upper right photo with your pontic sites being extremely shallow? We know those are going to be ginormous food traps. We know our patients are going to be complaining about space, about phonetics, and they're going to be driving us nuts. What if we're trying to do an RPD and we've got a distal extension and now, again, that partial is sitting on this wobbly base? Or, of course, our dreaded of all topics is trying to place a denture after we've extracted teeth on patients that now, over time, are going to have an atrophic maxilla. And we know the complaints that come both functionally and aesthetically. So these are all situations that each and every one on this call have come across a whole lot more than we'd like. I certainly have had my fair share of dealing with this. But through years of experience, I've developed techniques and gotten an understanding of the materials to be able to avoid ever being put into this situation. And that is what I'm so happy to share with each of you tonight. And again, to offer in much more depth for our invitation at the end of this course. So this is a situation that we all see. A patient comes in, they've cracked a tooth, and they need an extraction. Well, the question is, are we going to do this? Do we feel comfortable and confident enough to tackle this case? Or are we hesitant and debating whether or not this should be referred out to somebody else? Well, Part of the challenge with extractions is that looks can always be very deceiving. We might look at this case and say, well, the radiograph looks pretty simple. I don't really see any signs of lucency. It doesn't look like there's a lot of bone loss there. And clinically, well, there's a fracture there, but this doesn't seem like that big of a deal. I should be able to handle this pretty comfortably. But then sometimes the plot starts to thicken. We start noticing when we pay a little bit more attention that there might be some swelling up in the vestibule. You might even notice some suppuration. And of course, we're now in that situation where we have to make a very important decision. Do we feel confident and comfortable enough to tackle this case? Or are we maybe concerned that jumping into this case, it might turn into a much bigger deal and we may be a little bit too far in over our head? And our biggest nightmare is trying to tackle a case that at the beginning we think, no big deal, I got this. But once we go through the process of actually doing the work, we suddenly realize, oh my God, there are a huge amount of bony defects. There's soft tissue compromises. And again, the functional and the aesthetic outcomes, whether we're doing bridges, whether we're doing implants or partials, are going to make a huge impact on our overall results. So we have to start asking ourselves questions in terms of what can we do to better handle these cases. Some of those questions come down to the regenerative materials. Believe it or not, there could be a full day, and I give a full day course just on regenerative materials alone. So the question is going to be, how do I know in these clinical situations, what type of graft material am I using? Am I going for an allograft? Am I going for a xenograft? Am I maybe combining them? What are the indications where one material may be better than the other? What about these materials known as membranes? Am I going to be using something that is non-resorbable or resorbable? How am I going to put that on and get it fitted properly? These are all really important questions that the execution of which make a huge outcome in terms of our results. And of course, then comes the soft tissue management and the suturing. Are we going to employ vertical incisions? How are we going to prevent creating recession or losing the papilla? And how are we going to close these flaps in a way that is both passive, atraumatic, and will not result in the graft opening up? These are all really important questions. And the bottom line is that however many of these we have or haven't done, all of our goals as dental professionals are going to be the same. We want to have the best outcome for our patients. And our goal is to have a result where we have a case that we had just started with and we end in a situation like this, where we take a radiograph and our bone looks excellent. When we look clinically and we see that we have a very thick amount of attached tissue with a very good aesthetic outcome, whether or not we're placing a bridge, a partial, an implant, we now have a situation where we feel very confident and comfortable in our result. And the goal for all of us is to be able to, on a consistent and daily basis, have cases like this walk into our office. And rather than saying, I don't know if I can take this on, or I don't know if I should take this on. Instead, our goal through going through this course is to learn the tips and tricks to be able to get a case like this walking in and say, bring it on, I'm ready to go. And for those of you who are looking to reach that type of confidence and level, this is the course for you and why we are all here tonight. So our goal is to consistently start with whatever dramatic amount of a defect that we have and be able to end up with all the solid bone that we could possibly want. And we're going to help get you there. So what's so important? And I'm going to put up a couple keywords that always come to mind when it comes to extractions. And we're actually going to put a little poll up here as I go through this. So for those of you on the webinar, feel free to answer at your leisure. We'll come back to this at the very end. But what are the things we associate with these surgical extraction cases? Well, the first one I've already put up is the most obvious. These cases are stressful, and they should be. As a resident, they were very stressful because only the biggest and most involved were being referred my way, and it was expected that I was going to know how to handle these. But of course, as we're going to learn and we're going to talk about, unless we have the biology understanding and unless we know the surgical techniques, and more importantly, have the mentorship, repetition, and experience, we're not going to not be stressed. It's natural. These cases can be very difficult. The patients are in a lot of pain. They're having a lot of fear. And of course, it can lead to a lot of very dramatic outcomes for our results. The other big one is time. If you have an entire day of patients that are lined up and you've got other crown and bridge and other things going on, well, are we going to look at a case like this that walks in and say that it's worth our time? Or are we going to be so concerned that we don't have enough skills and experience doing this, that it's going to take us so long that the next thing is going to happen is that we're going to completely run behind in our day? And running behind is another huge factor that comes in. So we have to think about whether or not we feel comfortable in doing these because, well, we might be running behind. And of course, now our entire day is going to become a big struggle. And of course, our stress is going to go through the roof. And last but not least, the most common of all things is going to be fear. What if we have a big complication? What if the patient comes back later with swelling, with infection, or blames us, or has a bad aesthetic outcome? So again, for all of us that are very familiar with these types of situations, this is a course that is going to help you gain that confidence and give you the approaches to be able to tackle these cases with no fear and no leisure whatsoever. So a quick background about me and why I enjoy doing this and what I've dedicated myself into the academic teaching world. I am a board certified periodontist. I've been practicing full-time perio now for over 15 years. I did my training at Tufts for dental school, for the University of Pennsylvania for perio, and I've had the privilege of being a faculty member at Harvard Division of Perio for the last 15 years. And I am also an adjunct assistant professor at UPenn Perio. So my love, my passion has always been education. It's always been about giving back. I'm also fortunate enough to serve as the medical director of regeneration for Noble Biocare, which of course is good given our topic tonight. As mentioned, a proud member of the Catapult Education Speaker Bureau. And last but not least, something I may be the most proud of is that I've really dedicated my career to trying to address the really significant unaddressed things in dental school. So one of which is authoring a book called The Financial Survival Guide for Dentists, trying to help us. As we all know, we graduate, we're not ready for student loans, running our own business, knowing what a corporation is, the whole nine yards. And Ear Aid as well, a product I developed over a decade ago to help protect dental professionals against hearing loss, which is something, believe it or not, plagues us all and leads to a lot of serious systemic health issues. So this is all to say that my entire joy is to be able to help each and every one of our colleagues get better at everything that they do. And again, tonight's course is to try and aim and get each of you more confident and better, specifically in the topic of surgical extraction. So with that being said, we're going to dive into what we're going to be learning in our very brief but very information-packed session tonight. One of our key objectives is to discuss the top 3 mistakes dentists make with surgical extractions. We're going to provide 3 specific tips which are going to help you immediately to be able to apply these starting tomorrow in your practice to have better outcomes and better results. Another thing that we're going to discuss is a modern, predictable, step-by-step clinical approach. As dentists, the majority of us, we're type A, we're systematic. We're going to be able to provide a very basic overview of a step-by-step process that we go through to make every one of our extraction cases, no matter how complicated or how simple, straightforward, symptomatic, predictable. And those are the keys. And last but not least, we want to make this something that we can repeat over the long run. Again, as mentioned, it's all about having the confidence of knowing we can repeat this procedure all day long, over and over again, no matter what case comes our way. And so we're going to help get everybody into that position. As mentioned, again, at the very end, we're going to have a very special bonus section where we're going to introduce and I'm going to invite everybody to a very special program that will provide a roadmap to help elevate your skills through ongoing support. And as a final bonus, I'm going to be giving away tonight a free surgical instrumentation checklist. So stay tuned at the end as we go through that as well. I'm trying to provide as much as I can on this extremely involved topic in our short time. So let's jump in to our key objectives and start with the first tip. So one of the first tips that we all want to take away from this course in terms of really becoming good at these surgical extractions is understanding the fact that we need to plan ahead for these cases in order to minimize surprises. And what do I mean exactly by planning ahead? What I basically mean is before we ever even touch the patient, with the mirror, before we've ever given administered anesthesia, before we've started the extraction, we want to be able to, in our pre-planning phase, be as prepared as possible, not just for our treatment planning, but in also the way we introduce, explain the case to our patients, and of course, sell the cases themselves, because as we all know, ultimately, case closure is a huge part of our overall success as dental professionals. Now, when we talk about extraction cases, it's very important to understand that how we treat these cases, and I mentioned briefly on regenerative materials. Well, how do you know what material you're using? Well, part of that is going to depend on whether or not your extraction socket has any bony wall defects. So the bottom line is how we go about treating an extraction socket that has no bony wall defects is going to be very different from how we go about treating extraction sockets that do have bony wall defects. So part of what we have to do is be able to, in our pre-planning phase, identify whether or not the case that we're planning to tackle does in fact or doesn't in fact have this bony wall defect. And by being able to plan that on the front end, our ability to treatment plan and explain things to our patient and have the right materials in place to have the best outcomes is going to be dramatically higher. Well, first thing you might be asking is, well, what the heck's a bony wall defect to begin with? Well, it ends up that there are two specific kinds of bony wall defects, and these are really important to know because, first of all, from an anatomic standpoint, over 20% of our cortical plates already naturally have a bony wall defect. Then, if we start to incorporate different types of things like infection, fistulas, swellings, trauma, decay, etc., these can now exacerbate these numbers. And like I said, we need to see whether or not those are present both clinically and radiographically to then be able to determine how we're going to go about treating these cases. So when I speak about bony wall defects, there are two different types, one that is known as a fenestration, one that is known as a dehiscence. A fenestration is applying to a situation where when you have the area and you can see all of the bone, part of your buccal or palatal or lingual plate will be intact, but there is going to be a small window of bone where maybe you are missing, and you can see that in the picture circled there in the maxilla. Whereas something that is known as a dehiscence is the situation where rather than there being just a small window of bone missing, you have the entire buccal and or lingual palatal plate that is missing. And again, it is critical to be able to identify this because how we go about treating these are going to be vastly different, and we can figure a lot of this out on the front end. Now, one of the key ways we can figure this out is by having proper imaging. And of course, this is where 3D technology has, of course, changed the game. So if you are not employing 3D technology currently, it is greatly to your benefit to do so. These are great examples why. In this image alone, I can already identify the fact that there is no buccal plate. There is a dehiscence in that area. I can see where there is lucency around that. On the photo on the right, I can see that there's furcation involvement. Therefore, when I discuss this case with the patient from the treatment planning aspect, in terms of explaining, we talk about case closure. And one of the most difficult situations we all come across is where we think we have a very easy case, like we showed in our very first radiograph in this presentation. And we tell the patient, oh, this is just going to be an extraction. And then little do we know, we take the tooth out and end up seeing that it's a much bigger situation. And now we have to start including more bone grafting materials, membrane materials. And now we have to have that dreaded situation where we have to go back to our patient and say, yeah, I know I quoted you for X amount for this case, but actually things are a little bit different now. And we now have to actually do X in addition to Y. And of course, we know we get that dirty look from our patients. They're pissed. They're asking right away whether or not their insurance is going to cover it or not. And it can create a lot of situations where we even end up eating the cost. So really important if we have the proper imaging to be able to identify that. Critical here, look at this photo in the maxillary anterior for us to be able to identify, do we have a buccal plate or not? If so, how thin is that plate? Again, this is the most important area as far as the patients are concerned of their mouth. It's the most aesthetic area. So how we go about treatment planning and executing this case, so much of that information can be found out on the front end in terms of our treatment planning and how we're going to attack the case and what anatomic areas can be there. Of course, if we're talking in the posterior, we've got the maxillary sinus, or we've got the inferior alveolar or mental nerve. So many things that imagery can tell us. And far too often, I have seen, not only teaching in clinic, but in teaching courses like this around the country, how often we're a little bit too cavalier to jump into these cases without a very thorough radiographic and clinical case. We're just ready to jump in and take the tooth out without taking some of these considerations into effect. And again, that leads to negative outcomes. Another reason why we don't want to rely just on 2D. Believe it or not, this picture I just snapped with my iPhone yesterday, anticipation for our course tonight. This was a patient who had no pain, but they had a history of having a tongue ring for many years. A 2D periapical shows a little bit of a lucency there that they thought was endo-related. The tooth was totally vital, but it ends up that that tongue ring created trauma, which led to serious bone resorption. And believe me, guys, that picture does not do it justice. There was no bone, not only on the buccal, but there was nothing there on the lingual whatsoever. This was a through and through, front and back, completely open infection. And again, from a treatment planning standpoint, do we look at this case as being something straightforward and easy or something more involved? So these are things that having that 3D imagery and being able to plan things on the front end makes such a big difference. So I cannot underestimate the importance of planning your cases ahead. Now, the last point I'll make in this regard is also the way we discuss the process with our patient. First, we have to understand the biology. We have to know when we transition from having a fibrin clot within those first few days to having our first signs of osteoid within 1 week and having something that I speak with every single one of my patients about, this concept known as epithelial coverage. Now, you can see on that chart, it says about after day 38, which to me translates to about week number 6. This is so important because how many times are we getting a telephone call from our patients saying, hey, I think something's wrong. I think something is not healing properly. And when we ask, well, why do you think that? They say, well, because I feel like there's a hole in my mouth. I feel like I get food stuck in there. And how come it's not covering itself over? It still feels like a big gap. And of course, the reason for that is because biologically it takes a period of 6 weeks for that epithelium, like a dome at a stadium, to work its way up and over. So in each and every single one of my post-op conversations with my patients, I let them know that this process takes 6 weeks and that they should expect to have that space feeling and looking like it's open and possibly trapping some food in that area for that period of time. And the amount of times this has saved patients calling, being upset, being concerned or scared, and having to take our time and, of course, make them have a more negative experience. This has saved us a lot of this process. So again, the biology is really important to understand. The last part on this slide that I will point out is that the bone maturation process takes a very long time. We are all in the business nowadays of patients coming in and not just wanting us to do things quickly, but expecting us to do things quickly. So we have to make sure that we again explain to our patients how the biology works. I always remind all of my patients, look, if you fell and you happen to break your arm or your wrist, and the doctor told you you had to wear a cast for 3 months, are you going to take that cast off after 1 month and start going and exercising? Of course not. So when we tell you that this extraction site might need 3, 4, or 6 months to actually heal, we're not doing that because we're trying to trick you or we're trying to delay your treatment. We're doing it because the biology is going to dictate that and tells us how long these cases take. So again, really important, some easy take homes for everybody to understand. It's at week 2 that you first start to see signs of hard tissue formation within the socket. It takes about 1 month for hard tissue formation to happen over the wall of the socket. As mentioned, at week 6 is when we start to see that epithelial, that soft tissue coverage over the socket. And again, we don't really consider a socket to be quote unquote mature until bare minimum week number 12. So again, if you've ever been wondering why do we wait so long and why are these waiting times as long as they are, well, this is the reason. It's not that we want to make our patients wait. We all know that we'd love to get the work done ASAP, but the biology is dictating so, and it's important that we educate our patients on this point. So understanding that now from tip 1, we can all appreciate the fact that the more we can plan on the front end, both on our end from the clinical planning, but in our conversations to the patient and how we set up not only the case, but their expectations of what's going to be happening, the greater our chances of success. Now, what is tip number 2 when it comes to managing these surgical extraction cases? Well, as we all can imagine, technique matters. How we go about extracting these teeth in the most atraumatic fashion and preserving the maximum amount of bone as possible is going to make a huge impact, again, our key phrase, in both our functional and our aesthetic outcome. So when it comes to techniques, when we're talking about these surgical extractions, what are some of the key things that we want to keep in mind and some of the key armamentarium that can help us do our job better? Well, there are a couple of different techniques that we're going to just lightly touch on tonight, but will help give an overview of how we are approaching these cases. The first, of course, is the universal one that we're going to be talking about, and that is minimally traumatic extractions by doing something known as sectioning. And we'll talk about that in just a moment. Now, in a more in-depth session, we'll discuss techniques specific to the regenerative process, things known as like the ice cream cone technique, employing grafting with a membrane, or employing grafting with non-membranes, things like collagen plugs, bioplugs, and other type of materials that are there. So again, it's really important that we learn the biology and understand the cases that we are going into to know when we are going to use one of these techniques versus the other. What are the indications of doing one versus the other? And again, that is why we want to master these types of skills. Of course, last but not least, we cannot avoid understanding that we have to be able to manage the soft tissue, understanding when to employ a flap, how to employ the flap, and then how to manage that flap in terms of closure and post-op care, again, is going to be critical to post-op morbidity, complications, and our overall results. So there's a lot that has to do with technique, and we're going to tonight do a little bit of a deep dive in the step-by-step process for the actual sectioning and the extraction portion of these surgical extraction cases. So when we want to do these minimally or atraumatic extractions, we got to have the right instrumentation. Now, some of these you're all familiar with, but some of these maybe not. So we are always going to employ a high-speed handpiece, and we are always going to employ surgical length burrs. In order for us to extract these teeth effectively, you have to have a surgical link burr simply to be able to reach those very deep and very difficult areas to reach on roots that are broken, that are decayed. And let's face it, the majority of the cases that are going to be coming our way that are challenging are not going to be nice, healthy, intact teeth. They're going to be the broken root canal, decayed teeth, or that had trauma on them. So having a high-speed handpiece and surgical link burrs are really, really important. But equal to that are our actual instrumentation, these special instruments known as periotomes and exotomes. You're going to find that these instruments are precise. They allow you to extract teeth without damaging the bone, and they will allow you to extract teeth with such precision. We think of our traditional elevator and forceps, and I'm not saying you can't use them or that I don't use them, but I am trying to say that rather than going straight for the traditional elevator and forceps and putting a significant amount of force right away, first and foremost, I am utilizing these periotomes and exotomes. If we use them properly, they will do, if not the entire job for us, they will do a good 80 to 90% of the job with us in an atraumatic fashion because, again, our goal is to preserve as much of that bone as possible and to remove those teeth and those roots in as comfortable and atraumatic form as possible. So the key take homes as far as what we're going to do, if any tooth has multiple roots or frications, we are always going to section those teeth. I would take this a step further and say, even on single rooted teeth like maxillary centrals or canines, if they are deeply decayed or broken below the gingival margin and being able to reach them is very difficult to do, I am very oftentimes sectioning those teeth horizontally as well. The reason we want to section those teeth is that rather than trying to go into a tug of war with a one large piece tooth that is again decayed and broken down, we want to instead do something we call divide and conquer. We want to break that teeth up into its individual roots and be able to deal with each individual part separately with our periotome and exotome instruments. And by doing that, we can avoid causing damage to that critical buccal plate that we are all obsessed with. So not only do we want to section those teeth, not only do we want to use those periotomes and exotomes, but the other important thing which goes against so much of what we all learned in dental school is when we actually do decide to employ our forceps, rather than doing what we've been taught, which is put 2/3 of your pressure towards the buccal and then do it to the lingual, rather than doing that buccal lingual motion, we are actually going to employ a rotational motion, similar to what we would do for a conical rooted tooth. And the reason we're going to do that is because, once again, as you can appreciate in an aesthetic case like the maxillary central, for example, and in any of the other cases, which we're all going to come across where we have a very thin buccal plate, and we've got dramatic aesthetic and functional outcomes, we want to take away the pressure from that buccal plate as much as possible. And the way we can do that is by sectioning those teeth and employing this rotational motion. I will show you a quick picture and a video of that in a moment, but we'll go through the step-by-step right here. So step number one, we're going to use a high-speed handpiece. I'm going to discuss that in a moment. And we're also going to use, again, surgical length burrs. We want to have the longest burr possible to be able to provide us a great amount of length. Know that when we're dealing with natural tooth structure, a carbide surgical length burr will do the job. You can use a surgical 557. Here's another example of a surgical carbide burr I put up there. There are many different types. There's not a one burr does the trick only. But what we will say is that when we do need to section a tooth that has a crown there, if you either don't have a crown remover or are having a difficult time, know that you can use an aggressive diamond burr in order to be able to cut through that tooth, that crown structure as well. As soon as we are able to remove the crown structure from that tooth, we can then switch back to our surgical carbide and do the rest of the job. Now, when it comes to the high-speed handpiece, we really want to be sure that we, at all times possible when we can, use an electric handpiece. Now, why is that? Well, electric handpieces, as opposed to air-driven handpieces, which rely solely on speed, electric handpieces have a tremendous amount of torque. And when it comes to trying to cut through a bridge, porcelain metal structure, you all are familiar with that feeling when you're using an air-driven handpiece. It's taken forever. You're going through multiple burrs. Your arm starts to hurt. You start trying to put more pressure to no avail. Well, with an electric handpiece, because of the significant amount, it oftentimes has 4 to 5 times greater torque. We get consistent power, and our ability to cut through those teeth in a dramatically quicker fashion not only saves us a significant amount of time, which we all know, of course, adds to stress, but it will also save us a significant amount of energy, pain. I speak a lot on musculoskeletal breakdown, and we all have things like carpal tunnel and joint and nerve pain, again, from cutting through teeth and these heavy bridges. And of course, for our hearing as well, when we talk about overall hearing loss and being exposed to these loud levels of noise. So it's really important that we use an electric handpiece and these surgical burrs. Now, as mentioned, when we section teeth, our goal is to take a tooth that is in one piece and divide it into two individual pieces in the case of this mandibular molar. By going straight up the middle of the tooth and dividing it into its mesial and its distal roots, we now are able to focus on each root as its own single-rooted tooth, and again, use our periotomes and our exotomes to atraumatically extract those teeth. Now, you might be wondering, well, how does that work in the case of a maxillary molar that has 3 roots? Well, if you're looking at that photo and facing up is considered to be the buccal, the easiest way I always tell everybody is think of the Mercedes-Benz symbol. Now, you can pick what model Mercedes-Benz that you want, but you want to think of the Mercedes-Benz symbol and think that you're going to start right at the direct buccal in the midline. You're going to come down with your jaw right about to halfway, and then you're going to create your 2 lateral flares. And when you do that, you're going to take that maxillary molar and divide it into its mesial buccal, distal buccal, and its palatal root. And again, we now are dealing with 3 small individual single-rooted teeth rather than this one large, decayed, broken down, root canaled, hollowed, brittled tooth. And again, your ability to extract this in an atraumatic fashion and avoid putting pressure on that buccal plate is going to be dramatically higher, and it is going to be that way because we're going to be using those special instruments that I'm about to show. So again, whether you are going through a natural tooth structure or a tooth that has a restoration on it, we're going to section that tooth in half. Again, if that's your maxillary molar, you can see with this image, the way we've divided it into its 3 different roots. You can see what that looks like, again, with that Mercedes-Benz symbol there. And my ability to remove these 3 individual roots at a significantly faster, more atraumatic, less trauma on the patient, and preserving more bone is going to be significantly higher. And I can do this predictably, systematically, with every single patient that walks in the door. And again, it's about creating a flow and a system, not just for ourselves, but for our assistant and our team that's in the room, providing us the instruments and knowing what we are doing. So once we have sectioned that tooth, we mentioned this instrument known as a periotome. And you might be thinking, well, what's the point of a periotome? Well, as we all know, subsequently different from dental implants, around natural teeth, we always have this periodontal ligament around the tooth. And what this periotome is going to be able to do for us is that when we wiggle that into that PDL space, we're going to be able to start separating that PDL from the tooth itself. And by doing so, we've taken not only the first step in the process of starting to go through the process of luxating and loosening this tooth, but in addition to that, why that periotome is so important is because it's not going to damage that very thin and delicate bone. I'll show you a photo of that in just a little bit. But in addition to that, it is going to now set the stage for our next instrument known as the exotome. And the exotome, if you think about what that is, All an exotome is, everybody, is a very thin and angled and targeted elevator. So rather than having one elevator that has this giant handle that, of course, when we start putting that pressure up against that bone is creating a lot of stress and putting a lot more stress on the bone and causing fractures. These exotomes are angled. They can be targeted into the mesial, into the distal, specifically for the palatal root. They are very long, so you can imagine those endo teeth or those decayed teeth that break and they're very far up into that apical area where you almost have to lean over to just be able to see what you're looking at. They are long, they are narrow. You are able to get specifically in and wrap around those roots and then be able to push those teeth out. I'm going to show you a very quick example here where we have already sectioned our tooth. We are now using a periotome that is, an exotome, which is specifically targeted for that mesial root. And you can see the motion that I'm applying is very similar to what I would be doing with a traditional elevator, but again, in a much more atraumatic fashion. And believe it or not, I'm able to extract those teeth significantly quicker and easier. Now, of course, I'm not going to sit here and tell you every single tooth you take out with an exotome is going to be that quick. Of course not. Some cases are far more complicated than others. But I will tell you that having cases as quick as I just showed are not going to be the exception for you guys. It is going to be far more common than you think. And on those very challenging cases that have a narrow root or break or are very deep, your ability to go in there with a big fat elevator or a root tip pick that is also very aggressive, it's going to be challenging to do. But having that exotome that has that very long and very thin beak, your ability to reach and elevate in those areas is going to be dramatically improved. So these two instruments, guys, are literally lifesavers for us in the chair. Now, as mentioned, we don't avoid using traditional forceps when we take these teeth out. In fact, a lot of times, like I said, I'll do 80 or 90% of the work with my periotome or exotome until I've got that root completely nice and loose. But sometimes maybe there's a little bit of an undercut. Maybe it's just a hard area to reach. Maybe there's so much soft tissue around the tooth, I'm not able to grip it very well. No problem. Once I've already done the hard work with the periotomes and exotomes, I use forceps for the easy part. I now don't have to put a significant amount of force to remove the tooth. And as mentioned, which direction are we going to use our forceps? Are we going to do it the way we were told before, where we're going to push as much as we can, the heavy 2/3 of our force towards the buccal plate? Of course not. We have sectioned that tooth. We have an individual root. Just by doing our rotational motion, we're going to be able to do 90% of the job. And of course, that is so important because, again, our buccal plate is our lifeline, especially when we talk about aesthetics in the maxillary anterior, but even in the mandibular anterior, even on the posterior, especially if any of you on this webinar tonight are doing things like implants and even considering things like immediate implant placements. Man, having that buccal plate is everything, and being able to preserve as much of it is going to be critical. So again, rather than going buccal lingually, it makes no sense whatsoever. We're going to employ a rotational motion. So if we've sectioned our tooth, if we've used our periotome into that PDL space to start separating the root from the PDL, if we've used our targeted exotome to start getting that tooth super loose, we can now do the easy part and we can grab our forceps. And as you can see here, we can just do a nice, easy rotation with very minimal force whatsoever. And look at that, out comes our root. And as I mentioned, is every case going to be a slam dunk straightforward as that? Of course not. We're always going to have cases that are going to be more complicated. But I'm going to tell you, doing this, I don't know how many extractions per day, every single day, 5 days a week for 15 plus years, doing this technique, using the forceps to rotate that out, again, the ease of which I'm able to remove these teeth is not going to be the exception. It's going to be far more common than you can possibly think. So you can understand and appreciate that when teeth come our way, they're not going to be nice, whole, and intact. The reason they're getting referred our way is simply because of the fact that they are broken down. There's trauma. And you can see that periotome on that upper photo, how delicate it can start to separate the space in that area without damaging the tooth, because at the end of the day, our biggest nightmare and what we're trying to avoid is that scenario you're seeing on the bottom right, where did we get the tooth out? We sure did, but we also got a lot of bone, and now we're in trouble. So our goal ultimately is to try and have as much of an intact socket as humanly possible. Now, all this being said, there is a final reality, and that is every now and then there is going to be a situation where we're going to have to do something known as troughing. Whether there is an extremely curved root, a massive undercut, or maybe you have the situation where you have an extremely narrow endo-treated tooth within a huge amount of bone and it just chips its way down, we sometimes are going to have to take our high-speed handpiece and hold your breath here for the 2025 high-tech technology. Sorry about that. We're going to have to go around the root of that tooth, but you can do so, and we explain this in our surgical courses, how we can go around the perimeter of this tooth with a very thin burr and still keep our bony walls completely intact and not cause a fenestration or dehiscence. And our goal is to create a little bit of breathing room to then go back with our exotomes and get back into that space until the point that we can elevate that tooth. So know that these situations are going to come up. In some cases, we can avoid it. However, we can still do this in a way that will preserve the outer walls of the bone and allow us to treat these cases as if there were no bony wall defects. And again, that is the important thing to keep in mind. Last but not least, the most overlooked part is actually cleaning out the socket. Sounds straightforward enough, but both of these pictures that you see here are cases that were referred to me for implant placement, where on a 2D radiograph, it looked like there was all the bone in the world, but by the time we flapped the area and we cleaned out the soft tissue, it looked like the tooth just came out all over again. I have a very, very simple rule. And I will tell you right now, there is a specific curette I use that helps me get out all the soft tissue in 5 times quicker speed and in a very, very quick and effective manner. I have it for all of you in my bonus surgical instrumentation checklist at the end, so stay tuned for that. But I will share with you on this slide that I have a very easy rule for myself. It's 80-20 versus 20-80, which means however much time it takes me to extract that tooth, know that I am spending on average 4 times the amount of time that it took me to extract it, actually cleaning out the socket. It is the most important thing, because if you leave that infection in that area, you're not going to get a proper clot. It's going to complicate your results. And for those of you who are doing implants, you're going to have a significant amount more of complications as a result. Now, how do you know if you've gotten all the soft tissue out? Well, I have a very simple rule. I tell all of the residents at Harvard the same thing. The rule is this: as soon as you think you've cleaned out the socket, know that you haven't. That's the very easiest rule to do. So I do a very simple trick. As you can see here, I take a piece of gauze, I put it within the socket, I keep it in there with pressure for 10 or 15 seconds. I remove that gauze, and then I go in and I take a look. And I can guarantee you what you're going to find is that you're going to be going in and removing that gauze and suctioning out and curetting out more and more soft tissue. And every time you think you're done, remember my voice in your head telling you that you're not. Go put that gauze back in again. Go take a look. You're going to find there's more soft tissue. And you're going to go back and forth doing this process 3, 5, maybe 15 times before you take out all of that infection that is there. So that is why it is so important to have curettes that are very aggressive and can do the job. And again, I will highlight that for you in our bonus section. So again, keep in mind, what we see radiographically is always going to be much worse clinically. So a lot of times we'll get this case and it's like, oh, no problem, there's just a small radiolucency. And my answer is always small radiolucency, my ass. These cases are huge. And how are you going to know that you've got it all? Well, you want to do this gauze trick until the point where you see no more soft tissue within that area, that bleeding has gone away, and you have a nice intact site with no more infection and granulation tissue there. So keep yourself in mind. As soon as you think you're done, know that you are not. It is always bigger clinically than radiographically. But wait a second, what about those regenerative materials I talked about? Well, okay, now we understand how to take this tooth out, but what about the materials? How do we know what we're going to use? And well, the answer is in 50 minutes, I can't show you that. There's just so much to cover. There are four different types of bone grafts. Are we using an autograft? Are we using an allograft? If we're using an allograft, are we using one that is FDBA or DFDBA? Are we using a xenograft? And in what situation? There's so much more to this. And we start looking at membranes. Are we using one that is resorbable or non-resorbable? And of course, it gets even more deep because if we break down the resorbable category on its own, we then have to ask ourselves, is that resorbable membrane cross-linked or is it not cross-linked? So a big thing to understand is that the regenerative materials alone, we teach a full 8-hour course just on the materials. So there is so much more, of course, that I'm sure all of you know go into these surgical extraction cases. We're just able to touch on the technique of how to get the tooth out, but now that's only half the battle. Now we have to know in what clinical indication we use which material. We have to know, wait a second, what are we doing about flap management? Are we raising a flap or not? How do we reach the base of that infection to ensure that all the infection has been removed and that we can then place our regenerative material all the way to the apex to have a good result? How do we know when we do papilla preservation? When do we do a vertical incision? And if we do a vertical incision, how do we do it without causing scarring or recession? These things make a big impact. And of course, what about the suturing? How do we close the case in a way that is not going to cause more morbidity, that is passive in its closure, and that will keep the material exactly into the position that we want and stabilize our material? So of course, the fact of the matter is there is so much that goes into these cases that it's no wonder that we're all trying to learn this information and get better, because it takes a lot of work and time and repetition. And that's not even scratching the surface about talking about biologic material and doing things like PRF. So again, it just suffices to say that extractions are a very involved and deep topic, and I'd really encourage all of you to help and join us in doing this deeper dive as we continue to go through. Our goal is when we have these cases, we can now approach them in this very systematic way with our hand pieces on our instruments. We can section teeth, we can remove them atraumatically, we can preserve the bone. Based on our surgical indications that we did in our pre-planning phase, we can decide what's the best biomaterial to use, the best suturing technique, and lead to our best outcome. And that is our goal, and we want to do that systematically. So that's our tip 2, that is just the importance of the technique. But there is a final tip to wrap things up tonight that is maybe more overlooked than anything else, and that is simply that repetition with mentorship is the key. And what do I mean by this? I think all of us have one pain point in common, and that's the fact that as dentists, we are all in our own way lone wolves. The reality is that when we all graduated school, we had no help. We didn't know how to start our business. We didn't know how to pay our student loans, which is why I dedicated myself to trying to give back. But what do we do clinically? How do we know when these cases come up, how we go about best treating them? And the reality is our colleagues just say, I don't know, just go figure it out. Well, it doesn't have to be that way. What if we could have a program that would allow us, from the standpoint of mentorship, to have somebody over your shoulder to help guide you over a consistent period of time through repetition to be able to actually learn how to do these things consistently? Think about everything else we do. When we learn how to ride a bike, those of you who have tried to learn and speak another language, or those of you who did what I just did 2 weeks ago and learn how to drive stick shift for the very first time. Do we learn how to ride our bike on our very first try? Of course not. We go out with a parent who acts as our mentor or as our guide or as our coach, and we have them show us over and over and over again. When we learn a language, whether we're doing it online or on an app or in a class, we have a teacher that helps give us these lessons over and over and over again until we feel comfortable. And the fact of the matter is, when it comes to being a dental student or a resident, that's what dental school is all about. We didn't learn how to do an MOD or a crown or a flap in perio at our first time. Residents that I've had go through the Harvard program, they're doing as many surgeries as possible. But the reality is even when we graduate dental school or residency, we all know that we're not fully ready yet. So how could it be that we're going to master these surgical skills by just coming and doing a one-off training course? And the reality is we need not only help, but we need it at a consistent period of time and a form of mentorship and coaching. And what we found is that when we employ education via coaching and mentorship, we're able to dramatically increase the amount of productivity that we do. Why? Because we can learn things repetitively with confidence, and the better we are at doing it, the more we can start applying it to our cases across the board. I know all of us on this call, if we felt really confident in extracting these teeth in any case that came by, we'd be tackling more of these cases every day. And by doing so, we'd be keeping more work in our practices and increasing our outcomes and stop referring our patients out to be seen elsewhere. So the reality is, when we think about the education model, it needs to change because mostly what we do is we do a one-time training, and the reality is that the amount of productivity that we get versus having this repetitive type of teaching model and mentorship is going to be dramatically less. And this is why coaching is so important. So as much as I love doing courses like this, we're doing live courses, we're using the materials. The reality is all of you have done CE events like this, but how much of this material have you retained at the end of the course? And more importantly than that, at the start of the next week, when your patients come in, how much of that are you ready to use? How often does a thought come to your head of, wait, what was that suturing technique that they mentioned? What was that instrument that they said? How did they do that technique? Well, imagine if you had available to you at 24/7, not only the mentor, but those lessons virtually to be able to go and access, to be able to find that specific lesson that will apply to your case coming about. And that is the importance that we have to look at. We're all seeking for community. As dental professionals, we're used to having to do everything on our own, but we are all seeking this mentorship and this community aspect to be in a group of clinicians that are all in the same boat, that are not only learning the materials, but now we have a community where we can bounce ideas off one another. We can send each other cases that we're unsure about or we want a second opinion on and start getting that kind of feedback. And that is the special invitation that I want to provide to each and everybody on this call. So I'm going to discuss what that is, but to wrap up our educational portion right at the end of time, I want to highlight a few really important things that we went over. First thing, that our extraction success is always going to begin before we've ever touched the patient. Leverage imagery, anatomy, and the biology for better treatment planning and better overall results. Keep in mind that our atraumatic success depends on instrumentation and proper technique. Remember, divide and conquer. Make your life easier and more predictable. Now, of course, regenerative materials, flap designs, suture techniques are also essential parts to ridge preservation success. Of course, in a 50-minute webinar, there's no way that we can go and do a deep dive on this. However, we can help master all of these things by joining me in a very special program that I want to extend to all of you. My goal as an educator is to have each of you realize your ultimate outcome as surgical professionals. And I want each of you to be able to tackle these cases as if you were the specialist doing this and do it predictably as best as possible. And knowing that that mentorship and coaching is so, so critical. I've created a very unique course and offering that I'm wanting to share with everybody tonight, known as the Surgical Extraction and Grafting Accelerator course. This is going to be a 3-month mastery course that we go through every single material, technique, flap design, and in addition to that, help provide you not only with live mentorship. We're going to have monthly clinical mentorship calls where we go over different lessons for the day. We're also going to provide a case review portal where each and every one of you can submit a difficult case that you either had come across already and have questions about, or maybe a very difficult case that you have coming up that you want to get tips about. Again, this mentorship and community and being able to share this amongst your peers while having myself as your, again, your coach and your guide to help you master these cases as best as possible. We're going to have surgical planning protocols. There's going to be the tool list checklist. And at the end of that 3-month master course, we are also going to have a really fun live hands-on event, a full day of education, hands-on training, fun activities with one another, a night out on the town in sunny Southern California. So my goal, again, is not just to come and try and speak on one topic once and expect you all to be able to master it. We all know that's not possible. But by going through this process and by having somebody like myself who has that experience and wants to help and do this over a repetitive period of time, I have no doubt that each and every one of you can master these surgical extraction techniques to the point that you're going to want to have these cases coming into your practices every single day. And I wanted to thank each and every one of you for joining this call. I really hope you can all follow me on Instagram. I would love to stay in touch with you. You can see here I have the website with more information on the masterclass course called masterclinicalsurgery.com. You all also have my personal email there, so you can get in touch with me, whether it is by email or again by DMing me on Instagram. And again, I am very grateful for the opportunity tonight to be able to talk just a little bit about these surgical extraction cases. And of course, I would be honored to help you all master this moving forward in our masterclass course as well. So thank you so much for giving me an hour of your time at the end of a, I'm sure, very busy day, as it always is for all of us. I want to take a look at that poll right now and know for those of you that want to stick around, I'll stay as long as needed to answer whatever questions that you may have. Fantastic. So I want to take a peek here. So yeah, we had people in from Colorado. I see Texas, St. Louis, Chicago, Tennessee. It's great to see everybody from all over New Jersey, New Hampshire. Wow. So let me go through some of these questions that are being asked there. Let's pop through. First question here. What commonly used surgical burrs would you recommend? That's one question that was there. So again, when it comes to the actual carbide surgical length burr, I think the most common one that we have is the surgical length 557. That is a very easy burr that can cut through natural tooth structure very easily. Again, please keep in mind that if you are not able to remove the crown with a crown remover and you're wanting to section through, let's say, a bridge, for example, that you're going to want to use more aggressive type of diamond burr in order to be able to get through it. I've used those diamond burrs that are used to cut through zirconia, for example. So again, a lot of that is going to make a big impact there. So that's what you're going to want to use for those types of things. Question is, the next question, can we do the whole extraction with periotomes if the dentist is satisfied? So what you're going to find, Doc, is that you're not going to necessarily be able to extract the tooth with the periotome, but you will be able to extract the tooth using the exotomes. So a lot of times, again, the periotome is just to help widen and access the space in that PDL area, but it is the exotome that is going to help you get into that space, elevate, and yes, in many cases, you can do the entire extraction process with the exotome alone. So keep in mind that you can do that. It is not a problem whatsoever. But if you've gotten it loose and you feel like you're still not able to fully get it out, by all means at that point, because it has been now loosened, you can go back with your forcep and be able to grab that, or a bigger elevator if you need, because now you're going to be able to pop that root out without causing the damage. Another question here. Can improper cleaning cause bone graft failure? And the answer to that is yes, absolutely you can. If you do leave, and those two clinical photos that I showed earlier were actually cases that, again, had all that soft tissue in there. So if you even put bone graft into an area where you've left all of this infected tissue, imagine you've got an area with a big lucency and all this granulation infected tissue, and you leave it there. The ability for your bone graft to fully take, well, that's not going to be possible because that soft tissue has taken up a large portion of that socket. So how can that bone graft be able to fill in into that space where that soft tissue is? Keep in mind that the epithelium is always going to fill in that space faster than anything else is. So if you leave any epithelium behind, it is not going to be possible for that bone graft to be able to go all the way down and into that spot. So keep that in mind, and I hope that helps answer that question. Another question about when we recommend full closure, as far as I assume that means soft tissue. Again, great question. That is very case selective. That is very dependent on whether or not what type of material you're using, what type of membrane that you're using. Keep in mind that full closure is the majority of the time either not possible or not even recommended, because we are going to get, after 6 weeks, that soft tissue closure. And if you're obsessed too much about trying to get that primary closure, you are oftentimes going to take that mucogingival junction and you're going to pull it up so much coronally that you can actually leave the patient with a lack of soft tissue. And now you've got a soft tissue defect that you're going to have to address at a later time. So we'll do a deeper dive on that again in that mastery course. But the long story short is full closure in most of these situations is not something that you need to be too concerned about. Another question in terms of how we're removing those deep broken root tips. Again, that's where specifically those exotomes make that massive difference. I did touch upon the fact that we may need to do a little bit of troughing around that root area to help provide us that purchase point and access to get in. So know that that is something you may need to do, and that is totally okay. But trust me that those exotomes are going to make a huge, huge difference. Next question from a doctor here says, do you use chlorhexidine to help healing? And actually, that's a great question. The answer to that is actually no. We do not use chlorhexidine anymore. It has been found to cause long-term damage on fibroblasts. And as we know from the patient standpoint, it does a lot of staining and taste alteration. So two of the main things as far as rinsing, my go-to, it is, believe it or not, over the counter. It is a rinse known as Closis. Another company that you'll want to look into is known as Stella Life. Those two have, I would say, the best two rinses that are not going to cause the negative side effects and are going to give you excellent healing. So keep in mind those two as being two of the important things. Next question, I'm trying to get through all these for you. I noticed the gingiva round sites were minimally traumatized. How do you achieve this during the initial stages? Yes, so as far as your sectioning goes, it's really important when you're doing so, number one, making sure that you have that right burr that you're using, because again, if you're using burrs that are extremely fat, that is why we target that 557 or something very thin to try and avoid that. But at the same time, there's situations where, depending on the patient's biotype, if they have that very, very thin tissue, you're also going to have situations where you're going to get a little bit of soft tissue, adhesion and possibly small little, micro tears that are there. Again, that is a situation where you might be considering doing some of the flap access. So that's another thing to kind of keep in mind. But a lot of that also comes down to, again, your technique, and again, being just very straightforward and being very gentle there. Next question, go-to elevator. Again, my go-to elevator is actually the exotomes. And keep in mind that those exotomes come in an entire series. So those are the different ones I go to. By the time I've done my work with the exotomes, the elevator that I use it's really not that big of a deal anymore. I still opt for something that is longer and thinner. So again, employing less force and damage to the site. But again, the elevator is almost a secondary type of thing for me. So keep that in mind as best as you can. So another question is, if you're curetting the socket after the extraction, how do you know if you might be getting into the sinus or nerve and how to avoid it? Great question, a very important thing. Obviously, that is probably the biggest area where that 3D technology is going to make a dramatic difference for you, especially talking about the nerve. Keep in mind when you're talking about maxillary teeth, premolars or molars, there are going to be situations where going and having a small sinus perforation is completely unavoidable. If we think about our radiographs and you look at a 2D PA, you might have a sinus that is very low and you might have roots that are way up in there. So the chances of you removing that root without having some degree of sinus involvement, it's impossible, but that's okay. We go into a deep dive in terms of if you do have a little bit of a sinus exposure, how you actually go about addressing that and covering that access. But keep in mind, long story short, as far as your question as to how to avoid it, as far as the sinus goes, in some cases, it's unavoidable. If it's a case where that root is very close to the sinus, again, having that very atraumatic instrument makes a very big difference. If you have a much bigger and aggressive elevator, of course, your chances of causing a perforation are significantly higher. So that's another reason why you want to keep that in mind. So last question here. Do you ever remove palatal bone to get a purchase point for your palatal root? The long story short for that is in some situations you might need to, yes, but again, when you're doing that, you're not removing the palatal wall. You're going, since you've sectioned that tooth, more into that interproximal area to be able to get that out in a more atraumatic name again. So again, keep in mind that that's why you're going to be doing that. So last thing we're seeing here, I think there's one more question here. Are titanium coated instruments worth it? Well, there's actually 3 or 4 questions in once here. Air-driven 20 torque or 45. How many approximators? Again, a lot of questions here. The first one that's there are osteogen plugs. Again, that's a biomaterial question. I will say that those osteogen plugs in general are synthetic. I do not believe, based on what I've seen both clinically and just literature-wise, that you're going to get the overall type of bone regeneration that you will in using other type of materials. So in short, I would say that is not my go-to type of material to use with that. So I hope that can help suffice to answer that. We have got one more. As far as socket curettes go, again, if you take a look at that surgical list that I sent, I have provided the name of the company and the specific curette that I use. It has a serrated end. It comes from a company known as PDT, Paradise Dental Technologies. Feel free if you reach out to them to let them know that you are on this specific course with me. So who knows, maybe they'll hook you guys up. But again, that surgical curette has the best access, curated end, and multiple different spoon sizes to help you extract those atraumatically.